to ask, please.
Thank you so much. Thank you. The question is why one should incorporate toric IOLs into their practice. It's uh, it's very funny that there was a time when torics were looked at, harmless enemies, but now with the premium lenses, it's no more so. The cataract surgery treatment has reached the zenith where everything is taken care to achieve the utopia in visual happiness. Along with rapid visual rehab, many patients express the desire to be spectacle free after surgery. In today's scenario, the average age of a patient is coming down. So that makes it all the more reason. And if you want the youthful, clear vision, there are certain things because we have moved from spherical IOLs to zero aspheric to negative aspheric lenses. The journey continued from monofocals to refractive multifocals to diffractive, and now it continues into extended range and trifocals, and the astigmatism continues to remain one of the minor irritants on the way to achieve the ultimate goal. Corneal astigmatism is not very rare. It's a significant proportion of patients, and some studies have put it at 22 to 25%. Some studies say more have small or more of astigmatism, and that's the reason. And why are we bothered about astigmatism? Because it decreases the quality of vision. There is a meridional blur, the starburst and glare, and there is obviously diplopia. The advent of multifocal and trifocal lenses will require the pre-existing corneal astigmatism, even if it's small amount, to be addressed if the patient has to achieve spectacle independence. Over the years, astigmatism has been corrected either with spectacles, contact lenses, arcuate keratotomies. We have used toric, we have used LASIK, and here we are talking about a single procedure giving us. With ECC, the wound was large, there was no question, the healing was unpredictable, and with phaco, we have started going smaller and smaller. With obviously we thought we have minimal SIA, and there was a rebirth of incisional astigmatism correction, LRI or arcuate keratotomies. But then doing phaco with LRI for astigmatism, the results are at best unpredictable. There's always a regression. There is tectonic instability in question, and it is very difficult to titrate either small or big. The toric lenses today is the mainstay for management of cataract surgery because it is accurate, consistent, and predictable. And if you look at the studies, the percentage of extremely satisfied patients is 80% if post-op astigmatism is less than 0.5. And if the astigmatism goes little above 0.5, the extremely satisfied patient percentage rapidly drops down. Now, there is obviously higher patient expectation. There is increasing use of toric lenses, and toric lenses in fact today are used for even for a small cylinder. That's the reason we have the T2 series, which is very much used by many surgeons who wish to achieve 6.5, 6.6 after multifocal lenses. Our role in toric lenses to minimize all possible sources of error if you want to get final result at 0.5. And it's very systematic that a patient, when he comes and you diagnose to have astigmatism, he goes through certain distinct stations. First, his biometry is done, in between his counseling is done, then there is a transcription, then you have the planning stage, then you have the marking stage just before the surgery, then the issue of cyclotorsion that has to be taken into account, then we have the SIA that is caused by your incision size, you have the rhexis which has to be central, circular, and overlapping the lens. Then after that, finally you have to position the lens accurately, and if you really still can't, there has to be some amount of optimization. So that means at every stage there can be a lot of errors. Now, if it is pre-op keratometric measurements, gone are the days when we use one machine to do that. Like, you have to use more than one and kind of assess with your personal experience as to which particular case to be taken. I cannot overemphasize any question about corneal topography, because we know that if you want toric lenses to work well, your astigmatism has to be a regular one. Asymmetric ones probably won't give you good results. Toric IOL calculations today are done with several formulas. Each company will have its own online calculator. But today, among all, the universal Barrett online toric calculator seems to be giving you the best results, and most of us are on it. In your online calculator, they'll ask you for whether to include posterior corneal astigmatism, because that's another issue that we have to be looking at, and then the surgically induced astigmatism, because there is a lot that we know today about surgical astigmatism, induced astigmatism. At the start, it was considered insignificant for clear corneal phacoincisions, and then we learned that we still induce even at a small incision, and it ranged from 0.3 to 0.5. This began to be incorporated into toric calculators so that we don't miss out. And the SIA was calculated by taking the difference between post-op K and pre-op K, and the SIA calculation was done by using the vector analysis. And for example, after that we realized that around 0.3, 0.4, 0.5 kind of SIA we were getting. But what we didn't realize is that there was a fundamental drawback. We always thought an incision would cause relaxation in the same axis. But now we know that a given incision at temporal may not give you a relaxation in the same axis. It can still be in any of the axes, and that's the reason what we do is we go for centroid value, which is calculated by deriving the mean value from vector analysis, and it does it with a double angle plot. And this centroid value should be considered for SIA, and you can use different formulas. And today for most of us, if you are taken care with a good incision, your SIA comes as low as 0.1, because that's a mean. Then there is another factor, which is posterior corneal astigmatism, because most keratometers use only the measure from the anterior surface. But the logic tells us that, common sense tells us that if the anterior cornea is toric, there is likely to be some toricity on the posterior cornea as well, and this fact was completely ignored earlier. And PC surface, the posterior corneal surface, is always steeper vertically than horizontally, and because it's a minus lens, a vertical steepness will create plus refractive power along the horizontal, which in turn means if you are calculating for your toric power, you have to slightly undercorrect with the rule astigmatism or overcorrect against the rule astigmatism to neutralize the PCA. PCA can actually be measured by oculizer or pentacam, but what we normally do is our online calculators will take it into consideration. When using conventional keratometers, PCA accounted for in calculation can always be taken care with the formulas that we use.
Suhas, you have two minutes.
Okay, so when we come to OT, there's always a pre-op marking, and at every place like in this, you could use freehand marking, and freehand marking at 6 o'clock, which is more common with most of us. Then we have the sources in the intra-op period where the Mendes marker may not be at the accurate place, or your mark could be a little smudgy, or your rhexis is big and the lens is slightly decentered. And that's the reason we have what we call as a markerless system, which is a very systematic image planning and guide, and that's a Varion system where all the hassle of marking it pre-op, sitting position is all gone. You just take the patient, make a circular rhexis which is central and which tells you how much size to be taken. So in conclusion, what we know today is that astigmatism by its nature decreases vision quality for both near and far. And the correction of astigmatism provides a great and noticeable benefit to the patient. It helps a cataract surgeon achieve results which satisfy both him and the patient. And what we should remember is that astigmatic correction during cataract surgery is a medical necessity, and with evolution in toric IOL practice, toric lenses should be the method of choice in correcting astigmatism with cataract surgery. Thank you so much.